Good day, Saeed. Are you there? And Harshad.
Hi, John.
Hey, how you doing, Harshad?
I'm good. How are you?
Good, good. Let me get off my YouTube also.
Mhm.
How are you, John?
I asked you twice, how you doing, Harshad?
Yeah, I'm doing fine. It's late evening now, 10:15 p.m. in the night.
Late in the evening, huh? 10:30.
It seems
Yeah.
your Miami is bright and sunny.
Oh, it's beautiful, beautiful. Let me see if I can get the live camera. Hold on, because I normally keep the blinds closed.
Mm.
Let me give you a live shot here. Can you see that? Can you see okay? No, you can't see it? Oh, guess not.
It's bright.
It is very bright. It's beautiful.
How are you, John?
Hey, Saeed, how you doing?
Fine, and you?
Good. It's good to have you here.
Thank
And
you.
I'm glad to see you're starting the French, restarting the French broadcast.
Yes.
This
Friday, yes, Friday.
Yeah, we're going to push it this week.
Hmm.
And this is actually a good time to show people, because we're on YouTube. We're really not. Let's see here. Let me get
Yeah.
the banner up first.
Hmm.
Okay.
Hello.
I mean, Saeed, this is free advertising time, so take advantage of it. I'd like to introduce Saeed Taha. He's an ambitious, tech-smart neurosurgeon from the island of Reunion off the east coast of Africa. I didn't even know where it was until I looked at the map. But Saeed is here, and since we have some what they call in the industry dead time, you can take it away and tell us about what's coming up.
Okay.
Go ahead, Saeed.
Yes.
You want to introduce yourself and then tell us about the
yes.
webcast, please.
Yes, I'm a neurosurgeon from Reunion Island. It's Reunion Island is near Mauritius and near Madagascar. I'm neurosurgeon, a senior neurosurgeon, and I'm responsible of French neurosurgical rounds. That takes on Friday in general with French neurosurgeon, French-speaking neurosurgeon, but also the guests from the world.
Yes, we've been doing that for a while. Federico Di Rocco, good day. I'm Dr. Bennett.
Federico.
Yes, hello.
Hello, come on.
How are you?
Very
Fine,
good.
fine.
Comment
Nice to see you.
allez-vous?
Très bien, merci.
Have you met, do you know Saeed Taha?
Yes, of course.
Oh, okay. Okay. Good day, Mohammed. Where's Noor? Oh, this is more time that Noor. Hello, Noor.
Are you John? Can you hear me?
Yeah, Llewellyn, are you there? Good day, Llewellyn.
Are you John?
Good. How you been?
Yeah, good, good. It's been a while. Eh? Nice to see you again.
Yeah, good to see you again too. So basically, you're going to moderate with Muhammad, right?
That's right. Yeah.
Okay.
But
So
already-
should I introduce you first?
yeah. Well, either way, you know.
Yeah, then you just take it away, and you,
I'll
like just like before, after the webcast, you take over and you moderate the questions or comments.
Okay, great.
Okay.
Has Mohammed joined already? Yeah, I see.
Yeah,
his name.
Mohammed's here. He has, I don't know if he's not on his mic now. Mohammed, you there? He's in the panel. Let me just make sure he has his,
Hi, John.
I think his
Hi,
bandwidth
Llewellyn.
is, yeah, your bandwidth,
Good. You.
bandwidth is a little compromised, Mohammed. So, Mohammed, we may have to minimize your participation because of the bandwidth.
Okay.
Okay, I don't know if you want, maybe keep your camera off while you share, which is not a great experience, but we may have to do it because the bandwidth will just shut down the webcast. Not shut it down, but it'll, you know, it's no huge deal. You can still, let's try it. Come on the air now. Mohammed, let's try it now. Are you there? No. I think he's-
Yes.
Yeah, try, come on the air, see how it works okay. Are you there? Well, Mohammed? You may be rebooting.
Hi, sir. Hi, hello, everyone. Thank you so much for the wonderful.
We have what's called in the industry free airtime. So talk about your conference next in 3 weeks.
Oh, thank you so much. Thank you so much.
You can
sir.
screen share and tell us what's going on.
Oh, great. Actually, I didn't have the PPT right now, but we are going to conduct our module 2 next month. The exact date has not been, communicated and confirmed with Professor Luis Borba, since we are going to have WFNS Bogota next month, and there's another course on Scalp based in Rio where Professor Luis Borba will be quite busy. So the exact date is not yet confirmed. We will confirm it shortly. However, we are also conducting a conference on trauma. It will be a 2-day conference where we will also accept abstracts from neurosurgeons all around the world, preferably from the young neurosurgeons. So I think that it will be a matter of huge honor and pleasure for me to invite everyone right now to send their abstracts based on trauma, especially if you are located in the low middle income country and if you are a young neurosurgeon. Then we will be really pleased to receive your contribution for oral abstract that will be about 5 minutes long presentation. I will hopefully
Hey, Nora, don't take advantage of the free part. Hey, wait, Nora, let me show you something else coming up. We
Really?
have on Friday with Luis Borba and many other speakers.
Yeah, TBI.
Yeah, that's
What?
Friday. That's the WFNS of Nasser on Friday.
Wonderful. Yeah, I'll be there. I usually join Professor Nasrul Gandoor
Well,
meetings.
no, we're just relaying it from Neurosurgical TV. I don't know who's
Exactly.
broadcasting it. We're actually rebroadcasting it from their Facebook channel.
Oh yeah, wonderful. Yeah, exactly. I've been attending nearly all of his conferences. They are quite good and they are interesting. Because next month there is trauma and March is the trauma awareness month. So I wanted to organize a conference on trauma. But Professor Barber said that since March is a very busy month, otherwise because of WFNS meetings and Excel-based course, so it might be difficult to organize it in March. So probably we will organize it in April. However, the module 2 will be organized in March. It will be on radiology of the brain and the spine. We are also
I know it's free, but you're taking advantage of it. Hey, hold on. Let some other people. You guys, Llewellyn or Mohammed, you have any events you want to say coming up or something? Do you have anything coming up?
No. Yeah, well, we're just going to run the monthly CAANS pediatric
Okay. Okay.
That's amazing.
Okay.
That's
Very
really
good.
amazing.
John, just quick question. How many registrations did you have for this, you know?
I'm sorry, what's that?
Just registrations for this one, for this meeting, for this one.
No, you should be able to get in directly. Oh yeah, of course, all you have to register. You have to register for all of them, all of
Okay.
them.
For this meeting, do you know how many you have? Just so we have an idea.
Not yet, not yet. Right now there's 27 people in the panel. But more, generally speaking, the last 5 minutes, a lot of people come last minute.
Yeah. Okay. Okay. Great.
I predict 40 or 50 on the panel.
Okay. Great. Mo, you happy to go with that format we stuck to? I'll sort of introduce things and then hand over to you, or I'll introduce Federico and then you introduce John.
No, I just introduce you and you just run the show, just however you want. Questions, moderate, like things get slow, I'll try to jump in, but usually the docs can handle it. So
Did James join?
the panelists here, both the panel speakers here. I see Dr. Let's see. Federico's here and Mr. Dr. Johnston, right? We're waiting for.
Yeah, did he join yet, Johnston?
I don't see him yet. Let's see here.
Let's check the time with him, Mo. That's often an issue.
Yeah, I'm sending him now.
Are you in contact with Dr. Johnston, Llewellyn?
Mohammed's in contact with him.
Okay.
He said he is on, but he cannot talk.
Oh, there he is. I'm sorry.
He's
I'm sorry.
muted.
He is in. I'm a little slow in the mark here this morning. Okay, he should be in here momentarily. With 3 minutes to spare.
Hi, James.
Hello. Hey guys, how are you?
Great.
Hey, Dr. Johnson.
Good to see
Thank you for coming.
Nice to see you all.
No.
Yeah.
Thanks for joining at last moment. Yeah.
Oh, it's my pleasure. It actually worked out perfectly, so I'm happy to help.
Oh, thanks. Hi, Federico.
Hello. How are you?
Are you, Federico?
Everything okay? Thank you for the invitation.
Yeah, thanks for joining. Thanks so much.
Thanks for joining.
James, thanks for taking the time to join, James. Really appreciate you.
No, it's my pleasure. Seriously.
Okay. So just quickly, the program, we've got a minute or so. I'll sort of just introduce things and then hand over to Mohammed. I'll introduce Federico, who will talk first, and then we'll have a bit of a discussion after that, James, and then Mohammed will introduce you to follow on with the next talk. Is that all right?
Excellent. Excellent.
Okay, great.
Dr. Johnson, I didn't get your resume till late. Where are you at now?
I'm at University of Alabama in Birmingham.
Oh, great, great.
Yes.
The Bama Tide.
Yeah, Roll Tide.
Have you ever been to a game, a real thing?
I have.
I heard it's like a religious experience.
It is a religious experience. I'm from Denver originally, and I'm almost converted.
Yeah, it's a fervor there that you don't see in other parts of the country.
It's almost like it's almost as crazy as a soccer match, almost.
Almost. You get there. Okay, Llewellyn, you ready?
Yeah, we're good.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting at the home of Neurosurgical TV. And the background is just like this, the beach in the background. Anyways, I'd like to introduce you to the next CAANS WFNS collaboration, Pediatric Neurosurgery. And I'm going to turn over the program to Llewellyn Padiaki. Welcome, Llewellyn.
Thanks, John. Thanks so much. And again, thanks so much for all your effort in kind of disseminating, distributing, and kind of really sorting out the logistics. So just a quick sort of reintroduction. We had a month's break in January, but this is the CAANS Pediatric Neurosurgery webinar series run by Mohammed El-Beltagi and myself. And we've had tremendous support from the president of CAANS, Moody Qureshi, and the incoming president, Belu Shehu. So we'd like to just acknowledge their support as well. Mohammed, anything you want to say before we move on to introducing the speakers?
No, just want to thank John for the broadcasting, and of course, thanks James and Federico for joining. And we are back again for the monthly webinars, the second Tuesday each month, starting with these topics of synestosis. So please, Llewellyn.
Okay, thanks, Mo. So I'm going to move on in an effort to keep to time and introduce our first speaker. He's a very esteemed and respected international figure in pediatric neurosurgery, Professor Federico De Rocco. He's the professor and head of pediatric neurosurgery service at the Hôpital Femme Mère Enfant in Lyon. If I pronounce that wrong, Federico, you can correct my French with an Italian accent, yeah? He's occupied various executive board positions in ISPN, ESPN. He's widely published in most pediatric neurosurgery topics, especially craniofacial surgery, a service which he ran at the prestigious Hôpital Necker Enfant Malade in Paris for many years. So like I said, he's a respected international authority on craniofacial surgery, and we look forward to hearing some very useful insights and words of wisdom from him. So with that, Federico, I'm going to hand over to you. Do you want to
Thank you very much. Thank you, Wen, for the invitation, and to all of you for the opportunity to share my experience. And of course, it's a very complex to summarize in just a few minutes all the management of cranial synostosis. I think you can see my screen now. So we're going to discuss with James the different aspects. So since I don't know if there will be some kind of overlap or discussion on, but it will be, of course, very interesting, especially if we don't agree on some aspects. Of course, first of all, it's a course, so we need to start from the basis, from knowing the diagnosis, what is the natural history, and what is the management comes at the end. Of course, as a neurosurgeon, as a surgeon in general, we really want to rush on the surgery, but to understand this type of rare disease, you need to understand the natural history before proposing a surgery. So we're talking about rare disease. Incidence is 1 out of 2,500 births. It's heterogeneous with different subtypes, that are important to know. It is heterogeneous also because the physiology of the suture itself is complex. We know very little about this. We know some of the major genes that intervenes in the growth of the skull, in the growth of the suture. We know what can go wrong if the suture disappears, but we don't actually know what is beyond all that. We know that there is an interaction with the periosteum, there is an interaction with the dura mater. We know that if we can modify this in animal models, but the exact physiopathology of the synostosis is yet unknown. We know also that everything is complex because we have a double origin of the cells that will develop the skull vault and face. Sorry, we have neural crest cells and we have mesodermal cells. So the posterior part of the cranium is different in origin from the anterior part. But in terms of ossification, we have also different mechanisms because we have the vault being intramembranous growth and the skull base and part of the occipital being endochondral bone like for long bones. So we have two different mechanisms. We've explained you why sometimes we can have different bones affected and in others only the skull being affected. The skull growth will start from some ossification points. You will find one in each frontal bone, one in each parietal bone and occipital bone. And then this ossification will continue and the front of ossification will lead to the different suture. And these ossification points will also be separated by the growth itself of the skull. So if there is no growth of the skull, the bone will touch, and it will have a fusion, a secondary fusion due to a microcephaly more than a synostosis itself. So for a good growth of the skull and good shape, we need, of course, the patency of the suture, but we also need a growth of the brain and the dura and periosteum all together. So the suture itself will have a major role in the shape of this growth, because there will be the possibility of the two parietal bones, for example, in case of sagittal suture, to separate. And so you will see that the growth is perpendicular to the suture itself. When the suture is lost, like in the example on the right on the scaphocephaly, there will be only growth related to the coronal suture, so the growth will be parallel to the closed suture, and there will be no growth on longitudinally in this case. So you see that the suture are needed for having a normal growth of vector of the skull, and so you can also imagine that because these sutures are always in the same position, if you have a closure of one of these sutures, the shape and the growth vector will be modified, and at the end you will have a similar kind of shape. So this gives a skull dysmorphy when it's one or more sutures are primarily fused, and leads to a morphological diagnosis, because as we said in the example on the bottom, the sagittal suture is lost and the skull will elongate and will be narrow. It will be different, of course, if there is a coronal suture which is lost, in which there will be a scoliosis of the skull and face. Two coronals with a brachycephaly, the skull will be short and large. The trigonocephaly with a closure of the metopic, the forehead will be narrow and point. And in the lambdoid, which is more rare, you will have a deformation on the back with a different position of the ears. This morphology can be seen already antenatally, because it's an early ongoing process in most of the cases. It's a congenital disease in most of the cases, and you will be asked by your gynecologist colleagues to discuss with them about the morphological changes they will be able to see antenatally. So it is important to know that this modification can already be seen early, and that there is a very good correlation between antenatal imaging and the postnatal situation. As you see here, an antenatal CT scan in a kind of brachycephaly by the closure of the coronal suture, and you see that postnatally all the features of the craniofrontonasal dysplasia are clearly seen, and you could also recognize them antenatally. And you see that because of the early closure of the coronal suture, the lambdoid sutures and the sagittal and metopic are larger than expected because of the compensatory growth during the pregnancy. So a morphological diagnosis, it's a clinical diagnosis, and that can be done already in utero. What are the consequences of this fusion? Well, of course, there is a skull dysmorphy, the vault is affected, but also the skull base. So you see that there are different degrees, in the example on the right, a classification showing different degrees of skull base modification that can occur even if the problem is apparently only related to the coronal suture, but also the skull base is distorted. This skull is abnormal. Also, the brain will be. It is discussed what is primary, what is secondary due to the deformation of the skull, but easily you can understand that the deformation of the skull and the deformation of the brain are associated, even if we don't know exactly what is the chicken, what is the egg in some cases. And then there is an alteration in brain perfusion because there is a change in the local pressure, changes in the local CSF dynamics. You will have an alteration in brain perfusion that brain analysis imaging can confirm. And as I said, there is also altered CSF dynamics. This is an example of the measurements of the pericerebral effusion in scaphocephaly, and you see that you had clearly two types of children, those with a larger CSF spaces than expected for their age. The black curve is what is expected at the age of the child, the normal values, and you see that there are children with very high values of CSF and others with very low values. So again, an heterogeneity and different subtypes and different alteration on the CSF dynamics. And obviously, there is also the problem of the compliance of the skull with a cranial encephalic disproportion. There is less volume for the brain, and you see here the example in the this Brachycephaly, that there is less room on one side, the hemicranium is large on the other side, so all the growth of one side of the brain, of one hemisphere, will be affected with the compensatory growth on the other side. And of course, you can imagine that there is a repercussion also in the position of the folks, in the position of the sagittal sinuses that are also affected in their anatomical growth. So the local volume can be changed, and the cranioencephalic disproportion can exist both at the level of supratentorial, infratentorial, and this might lead to a raised intracranial pressure, especially when several sutures are affected, and you will see that on the imaging and during the surgery with the modification on the bone and on the dural matter. And when you measure the ICP, you will see that figures of raised ICP can be found in all types of craniosynostosis with different risk. The more sutures are closed, the higher the risk of a raised ICP, especially as oxycephaly, Cruzon, and Pfeiffer syndromes. This raise in ICP can lead to a visual impairment, problems with sight, and neurocognitive delay if it is not treated. Of course, this is even worse in case of fascicular synostosis, in which you will have also problems in the oxygenation of the brain due to respiratory problems, due to the midface protrusion, due to the hydrocephalus, or due to the Chiari malformation, the descent of the tonsil that is more common in children with fascicular synostosis. So fascicular synostosis is a subtype of craniosynostosis in which also the growth of the face, and you can understand easily due to the common embryological pattern that also the face can be affected in children with craniosynostosis. What you will have in these cases, as I said, you can have the severe cases as I show you, or milder cases. So you see here an example of milder intrusion, but the coronal suture and lambdoid suture are less visible. You see still a little of the sagittal suture. You see the different thumbprinting, and you see the modification in foramen magnum. You see the position of the crowded posterior fossa, and you can also see the abnormal venous outflow, which will impair the circulation, the venous circulation. And of course, you need to know that if you want to do a surgery in that region, because of the risk for the patient if you interrupt the outflow from the brain. There is a high risk of neurological sequelae, especially in the multisutural one, because of the synostosis as we discussed, because also of the hydrocephalus, because of the airway obstruction, the risk of central apneas, or peripheral one due to the midface protrusion, the problem of the venous hypertension related to the stenosis of the jugular foramina, and the Chiari malformation. So all of this can lead to raised ICP and neurological sequelae if not treated. And there is also the risk of having problems in the anatomy of the brain, like in Apert syndrome with corpus callosum agenesis, or in its function, though apparently normal on the imaging, because there are some of the genes that lead to the synostosis that also are involved in the development and function of the brain. So there is also a higher risk of neurological sequelae statistically with all types of craniosynostosis, independent by the synostosis itself. The typical example is Apert syndrome, which is now well known. You see that there is a brachycephaly, there are modifications in the face, in the palate, and of course the typical syndactyly of the hands and feet that leads to diagnosis nowadays in most of the cases already at the intrauterine examination. But you can have also milder modification. You see, this is more recent, just to show you the fact that this is still evolving field with some genes that have been recognized 10 years ago now. This is TCF12, giving a brachycephaly, and you can also have milder modification of the ears and the feet, which you need to examine in order to do the proper diagnosis in the children. There are yet several genes that are more known nowadays. As I told you, it's a field which is still evolving. These genes are known to develop, to be necessary for the normal development of the skull. Some of them are particularly involved in cranial synostosis. These are the family of FGFR, especially 2 and 3, but all of these, the twist and the TCF12 I just showed you, are involved. And it's important to know what mutation will be found, because it will impact the growth, the general growth and the outcome of the child also. So it's important for the surgeon to know what is behind. And just to make a parallel, you know that posterior fossa medulloblastoma are divided in subtypes. They will change the prognosis. This is the same in the synostosis. The prognosis can be changed by the gene which is affected. And we know now better to correlate the clinical features to the mutation that is found. And you see that again that there is an impact, because depending on the type of mutation, and sometimes you need to go down to the amino acid mutation, you will find some more severe or phenotypes in terms of outcome, in terms of need of surgical procedures. So you can foresee if the child will have several surgeries or a bad outcome. Going back to the simple classification, because of course these are more complex classifications, sometimes you need sorry, the help of a genetist. Going back to the typical Manichaean vision of the surgeon, we have isolated, non-isolated, simple versus complex synostosis with different risks and problems at stake, of course. The isolated ones are mostly unisutural. The isolated are mostly syndromic with a genetic background, underlying disease, uni or multisutural. But as you try to explain, it's sometimes difficult to really classify isolated and non-isolated purely on a clinical basis. You will need to know the genetic background. This is an example. Clinically, you see that there's a dolichocephaly, a typical appearance of a scaphocephaly, but there is a FGFR2 mutation, which will the phenotype of which will become more overstated during time. You see the abnormal growth of the face, the typical breathing with the open mouth. At that time, the diagnosis is simple, but it's important for the surgeon to know that it is Proud zone syndrome, so you can explain the parents the evolution. You can anticipate the need for several surgeries and just not reassure them too early that one surgery will be enough for the child when you see when it has 2 or 3 months. So the proper diagnosis is essential for the proper management and improving the final outcome. So it needs the combination of knowledge from the radiology, genetics, and your clinical findings. This is another example. You see on the imaging, there is only coronal suture which is lost with a mild modification, but of course, we are talking about a much more severe disease. It's osteopetrosis that we will need a bone marrow transplantation to be cured, and not only craniofacial surgery, even if the child comes for the problem of the symmetry of the face and skull. So again, it's important to put the patient in a more general setting. Another example to show you why it is important, you see here a child that came for a simple scaphocephaly, 2007, and the sensory brain syndrome that was present was not diagnosed at that time, it was missed. And then the child comes back several years later when his kidney function is very low. He needs a kidney transplantation at that time, and the diagnosis could have been done earlier, would have changed the management and the outcome for this child. So it's important to distinguish the management of the cranial synostosis from the osteotomy, from the surgical procedure, which is something completely different. So what are the goals of your management? Of course, it's to allow to develop the child normally, so you will avoid any encephalic compression, correct the dysmorphy, restore the CSF dynamics, and counteract the progression of the anomalies that you know will appear. And there are 2 main types of surgery. You can do an early prophylactic one when the child is very young or when it's asymptomatic, just to avoid the problem of future raised ICP, to improve the morphology. Or you can do a curative surgery when the child is symptomatic. What are the examination you need? As we said, for the diagnosis, no investigation is actually needed. You can do it clinically, but if you want to be sure that is an isolated one, you will need the help of the radiology genetics. And to know if it's symptomatic or not, sometimes you need to go to endoscopy ICP monitoring in some cases. And of course, in the complex one, you will need to eliminate or to analyze the posterior fossa, the chiari, the syngomida that you can find, the MRI. You will need to a proper molecular diagnosis and polysomnography to know exactly the status of your child. What can be done? There exist several craniofacial techniques that can be used to deal with the different parts of the skull. You can do a anteriorly frontal or a frontal orbital advancement. You can do a vault remodeling. You can do a posterior vault distraction, or you can do also foramen magnum decompression in some cases that I put here, even if it's not technically a craniofacial technique. So the principle, the basic principle is you want to open the skull, you want to restore the suture line, and you want to improve the shape and future growth. So the simplest techniques that have been designed are to remove the bones during purely an osteotomy of a suturectomy. We know will not give the in all the cases very good results and a very good outcome. So you need to do more than the pure suturectomy. You can do an example here, the removal of the closed zone around the sinus. It's always better to start laterally to the sinus to avoid any damage of it. If you stay 2 centimeters from the side, you will not have any problem. Then you do a parietal remodeling. You see here green streak fracture, which allows you to have immediately a change in the shape and the R. And you can also control, if you want, with a radiological imaging, just to show you that the results are immediate and will stay. If you don't want to take any risk, there is also the possibility to just do the compressive flaps. But of course, the aesthetic results will be poorer, but this is what is probably better in older children to avoid any bleeding with the sagittal sinus that can be encased in the bone. Of course, sometimes you need to do a more extended procedure when the child is older. You can, as I said, remodel completely and recover completely the flaps. And in other cases, as in the Brachycephaly, you need to go to treat also the front and the bandeau, because all these anomalies affect the symmetry of the skull, and you want to restore a symmetry with an overcorrection of your frontal orbital bandeau, which you will be able to cut with different tools. Here, these examples with the piezoelectric, which allows you to have less bone loss and less bleeding from the bone. And then you will remove the forehead, and then you will reconstruct, and you will position this new bandeau more anteriorly, creating a gap in order to have a slight overcorrection, and then a symmetry that can be found. And you can use stitches or plates, resolvable plates. This example just to show you that you can have something that can stay during time after several years. Same thing for the trigon, in which you want, again, to open the vault and to restore the symmetry and the normal shape of the bandeau. This is a quick example. Here, the idea, you have to be careful, because in this region, there are some veins that increase the risk of bleeding. These metomic veins, you can avoid them during the burrow hole here and leaving this triangular part in the middle. Again, the use of the piezo in this case. So we go around the veins we know are here, and then so I will just go quickly. You will remove the forehead. You see here the hole, and you leave here, and this procedure will not bleed. And then you can directly control the veins from lateral, and then you will restore this part, and this will allow you to avoid unnecessary bleeding with higher risk of transfusion, because you are operating on these veins that you will cut if you go directly with the osteotomy here on the middle. The same principle is used for the brachycephaly. Your advancements of the forehead and bandeau will be symmetric in this case, which again here you see that some growth and some stitches will allow you to have good results. You can also use plates, and you can associate the modification of the bandeau and forehead also to the change on the parietal region in order to change the shape when more sutures are affected. Posteriorly, also, you can change the shape of the posterior wall. This is interesting in crowded posterior fossa, like in the Mercedes type. The Mercedes type is a sagittal suture closure and lambdoid suture closure, and you can increase with this type of procedures the shape, and you see here that allows you to have also more space for the cerebellum, which of course is better for the development of the child. The complication of these procedures, as I said, are mainly related to blood losses. So it's a surgery that has a risk of mortality. People usually tend to forget because they see big teams with lots of experience when they train. And in most of the cases, when they go in smaller centers, then they are faced with the risk of having high morbidity and mortality. So really remember that there is a risk of high risk of blood losses. You need to transfuse these children and to be sure that in the post-operative period also they don't have problems. Problems occur for the scapulocephaly surgery, during the surgery, but also in the first hours after the surgery due to the blood losses after the recovery. So you need an intensivist, you need a pediatric anesthetist that know all of these problems before starting doing this type of surgery. Of course, there is a risk of dural tears and cortical damage. You are not careful with your osteotomies, and this risk is increased in case of raised ICP with this honeycomb bone and risk of dural tears in these cases. Of course, there is also risk of insufficient correction and recurrence. This is especially true in syndromic cases, and this is again why it is important to know what type of syndrome you're dealing with, because the risk of recurrence will change according to the type of syndrome. Because of all these risks, different techniques have been developed in the last years, mainly the concept of using minimal invasive techniques to reduce the blood losses, stage surgery, again to reduce the risk, and using hardware material in order to, again, to reduce the risk of the procedures. So, for example, in the scapulocephaly, now there are several techniques that can be used. The endoscopic approach, the use of springs, which will push the two bones separately, or the destructors used to separate the different bones. Of course, when you use springs and destructors, you will need a second surgery to remove these elements. Or you can use also the minimal invasive cranial bone reconstruction, which is targeted incision in order to reach the same type of osteotomy, but with only few cuts at the different parts. So this is an example of what you can do for the endoscopy. You can do with two incisions, one at the level of anterior to the lambda, one posterior to the brecma, and then from this approach, you will be able to, I'm sorry for the video, you will put the endoscope underneath, and you will separate the bone from the dura mater, coagulate the veins, and then you will be able to cut and to remove. And then you will put an helmet in order to improve the shape, even if it's not necessary in all cases, depending on the osteotomy you can reach, and then you will see the shape of the child that will improve. You see here, this is a recent case with the typical narrowing of the posterior region. Then after the surgery and after the helmet, you can improve the shape and normalize the growth. Same thing with the use of hardware. These are destructors that can be used in order to avoid removing the flap from the dura mater. Normally, in the posterior remodeling, you will have to elevate completely your flap, and so there is a higher risk of dural tear and bleeding. With this technique, you just do the osteotomy, and then you put the destructors, and you will turn this destructor on the gap between the two parts of the destructor will increase of 1 millimeter every day, and you will pull the dura and the dural sinuses progressively, and so there is no risk or very little risk of dural tears and major bleeding with the technique which is more essential, is very important, especially in the children with the abnormal venous congestion that they can have in this synostosis. And so you can have this type of flap, and you will increase this size, and you will little by little changing the numbers of turns you will do, correct also an asymmetry. So there's been an evolution in the past decades in the strategy for isolated synostosis, going from the purely suturectomy, as I said, with insufficient results in many cases, to a total vault craniectomy, which was very invasive, to stage or minimal invasive techniques with helmets in order to decrease the morbidity and mortality. For the complex synostosis, of course, there is the scalp remodeling, but it's not only that. As we said, there is also the chiari, there's also the hydrocephalus, and there are all the other problems related to the face, eyes, the mouth, and so on. So you will need a cooperation with your maxillofacial colleagues, ophthalmologists, ENT, plastic surgeons. Again, the goals of the surgery is to limit the neurologic impairment related to the raised ICP, restore the function with the least number of operations. So you see again the problem of hydrocephalus. You see antenatal small ventricles and postnatal large ventricles in this complex synostosis. So in the case of syndromic cases, you need to be prepared to an evolution, rapid evolution in the postnatal life. And so in some cases, you will need to do CSF shunting. So you see here the combination of using the shunt for the ventricles and the flap in order to restore the morphology and volume of the posterior part of the skull. As I said, things can change rapidly in case of syndromic synostosis. You see here day 1 and 1 month later, important descent of the tonsils. These syndromic cases are evolutive disease, and it's important again to note that this evolution also affects the different foramina of the jugular foramina, and you can have very large veins draining the all the blood from the skull, and so you really don't want to tear them, otherwise you will have a major issue with the survival of the child. The facial advancement will allow you also to improve the protection of the globe, to resolve the dysmorphy and improve the breathing, because you will open the airways. So there is also a functional surgery for the functional outcome, which is important to follow in these cases. What you can do is 2 steps or 1 step. This is in 1 step. It's a frontal facial advancement. You see here, this is the orbits that are cut. The face is standing here. And there is also this destructor, which will move the mid-face after your maxillofacial colleagues have done the equivalent of a Le Fort, which is associated to the I'm sorry, I cannot. Yes, here it is. So you see here the cut, you see the forehead, the bandeau, and then here the face, the sternum goes down here, and the different destructor will advance the all the front and face simultaneously. Of course, you can also do into steps, typical frontal orbital, and then a little free later on. So why it's important to know all that? Because the airway stenosis has also repercussion on the final outcome. So in case of severe facial stenosis, you will need a primary treatment for airway liberation, sometimes a tracheostomy, sometimes the orbital advancement and the facial advancement. So different surgeries are needed. Generally, in infancy, you will have to do a CSF shunt or ETV in some cases. You can do a cranioplasty, of course, in very young, and sometimes you need to redo it. Facial advancement later on to protect the eyes and improve breathing and for cosmesis, and then also the ENT surgery and the ophthalmological surgery, which are needed during childhood and adolescence. And so, again, there has been a trend to move from very invasive surgery to stage correction in order to reduce the morbidity of all of these different procedures. However, we really need to consider that there is an important morbidity And sometimes the results, even if you do all this, will remain poor because of the genetic expression of the mutation on the brain. Nevertheless, what we try to do now is a stage release using eventual destruction starting from the posteriorly in order to have a larger increase in volume, which you can achieve with the posterior advancement. And then you will have a milder need or little changes for aesthetic reason in the anterior part of the skull and face. Again, to show you the interest of the modification, is that you can increase a large amount of volume, which will not be possible for aesthetic and functional reason in the front. So you can displace the bones significantly. You can even go down to 3 centimeters, and this will allow you to improve the situation even in the posterior fossa. So you see that these changes again has an impact on the brain. You see here the indirect modification in the structure of the brain, corpus callosum and so on, but also in the carry and the prevention of the problems related to descent and the assembly. So in conclusion, what you want is to avoid any encephalic compression. You want to restore CSF dynamics at the level of the ventricles, but also the posterior fossa. You want to counteract the progression of the anomalies, and of course correct the cranial dysmorphy, but this is not the main objective as a neurosurgeon. We are not plastic surgeon. We need to remember that our main goal is to protect the brain and to normalize its growth. You need to master these different techniques because you need to tailor to the single patient. So everybody always wants to tailor the surgery to the patient, but tailoring to the patient means that you need to know the advantages and inconvenience of different techniques, and you need to be able to perform them if needed. And then you will be able to really propose to the child, this is better to do open vault, this is better to do endoscopic, we are better to start with the distraction, because you are able to know the advantages of this stage surgery. And of course, you need, as we said, a multidisciplinary team to treat all this pathology, because it's a lifelong commitment that these children will grow, and they will need somebody who knows what the natural history is, what the pathology is, in order to treat them correctly. And of course, you can do that if you know exactly what type of genetic diagnosis or syndrome they have. As I show you, sometimes you can have complications that will appear several years later if you don't properly know your patient before. So as I said, multidisciplinarity, genetics, pediatric, gynecologist, of course, other type of surgeon, maxillofacial, plastic ENT, and so on, but also all the nurses, the physiotherapy, neuropsychologists, and psychologists, which are essential to accompany these patients and their families. So thank you very much, and I finished just inviting you, for those who are interested in craniofacial, to the meeting of the Craniofacial Society in Europe that will be in Oxford next September. Thank you very much.
Thanks, Federico. That was an absolute tour de force, a really fantastic masterclass. So thanks for a usual spectacular talk. So I've got a couple of questions. I'm just going to look into the chat firstly to see. Before I do that, I want to welcome Belu Shehu, who's the incoming president of CAANS. I see he managed to join. Belu, if you could unmute yourself maybe, and just you can have the privilege of asking the first question.
Thank you very much, Llewellyn. I think it's a wonderful presentation. I wasn't here at the beginning, but what I wanted quickly to know is that how long do you keep the distractors? I know that you said you start removing. I haven't used distractors myself, but it's the question that you can get so much with the distractors in place. But how long overall, from the beginning, from the end of surgery, when do you remove the last distractor? Because that's a bit of a problem.
Yeah. So the distractor, the principle is that you place them, then you leave them some days in order to consolidate. Then you start the distractor. The typical growth rate is 1 millimeter per day, which is used for long bone, the face. If you're using them for the posterior region, you can go faster because there will be also the growth of the brain, which will continue. So you can go even faster. So generally, after 2 weeks, 3 weeks, you are finishing and reach your objective. Then you stop and you wait for a minimal ossification in order to be able to remove them. The problem is that the food destructor, there might be a contamination with germs and others. So this really depends on the setting you're working. What you can do is, once you have reached this position, when you remove them, you put a plate or you put a bone in order to reduce the risk of displacement of your bone flap. So either you wait 3 months and you will have a natural ossification and then you remove them, or you prefer to be on the safe side from infection, you remove them after 3-4 weeks, and then at that point you need to stabilize to be sure that you will not go back. But generally on the posterior region, it will not go back, because once the brain has developed, it will not be squeezed again.
Thank you very much.
Excuse me, Federico, we want to put our best foot forward for the president. Could you move your camera up a little bit? Yeah, there we go. Okay.
Thank you very much.
Okay.
Thanks so much, Bello. Mo, any questions or comments from your side before I so move it on to some of the panelists?
Yeah, thanks, Federico, for the nice, wonderful presentation. I just want to know, if you don't have the helmet, so what are the other alternatives? As you know, in Africa, we don't usually have helmet. And if we are doing this in the early age, 3 months and below, 6 months or below, we can use still this helmet. But after that, what are the alternatives which you would recommend?
Thank you, Mohamed. The helmet is very useful when you do endoscopic surgery in a very young one. So ideally 3 months of age. And then you can limit yourself to do a larger suturectomy, and then the helmet will continue to reshape the skull. If you don't have an helmet, you can modify your osteotomy, including lateral osteotomy, parietal osteotomies, occipital osteotomies, and then you ask the parents to put the child prone with the head on the back, stick, like if you were to have a positional brachycephaly. So you need to immobilize the child during the rest. In a cozy, you need to put that back to sleep, stuck in a position which you usually didn't have before, because schistocephalic patients always force them to be really straight. And at that point, you will use the gravity to enlarge the parietal bones, and you don't need an helmet in this case.
Yeah. Okay. Thank you.
But
Federico.
you need to do very early, 3 months. After will be to
But after 6 months, like 6 months age.
At 6 months, you will do a back coronal incision, and then a parietal remodeling, eventually also forehead or occipital, depending on the deformation, and then you don't need the helmet anymore.
Okay. Thanks.
So,
any more questions? Llewellyn?
Yeah, I see there are 1 or 2, but on that note, I just want to ask you maybe a slightly more philosophical question. So the principles of management tend to cycle from maximal exposure, suturectomies, all the way down to the skull base, because the theory still suggests that synestosis is a skull-based related primarily disease, and then has advanced to endoscopic assisted springs, bone scalpels. Sandeep Sood published a paper a couple of years ago saying you don't need to do any of that. You can just use a helmet, and it corrects, some cases of sagittal synestosis. So let me get your thoughts on that. I know it's controversial.
There have been several studies but the helmet is sufficient to correct the morphology. But again, the question is, what is the aim of the surgery? If the aim of the surgery is to correct the morphology, the helmet is the solution. This is something that has been demonstrated in several studies, and we know since the beginning of mankind, we can change the shape of the head to be in one tribe or another. So this is not the problem. The problem is, what is the aim? And in some cases, as I show you, there are CSF anomalies. There are problems in the cerebral pressure. If you block the deformation you have in the scephocephaly is, in some cases at least, the compensation of the growth of the brain, because it cannot enlarge. You want to push anteriorly or posteriorly. If you restrain this compensatory growth, there is a constriction in all the direction. So the overall results from an aesthetic point of view would be nice, but from a functional point of view, we can question the safety of these procedures. So again, this is why we really need to know what we want to do. If we're doing a plastic surgery discussion, you can do a helmet, you can do the so-called P technique, in which I remind you, for those who are not familiar, you do two-parietal flap, you leave the compression of the bone on the midline, and you pull the forehead to posteriorly. So you increase the pressure on the brain. If you put an epidural ICP monitor during this type of procedure, your child is under general anesthesia, you put in the forehead region, the pressure is around 2 or 3. You pull, and you will see that your pressure goes to 15. So again, if the objective was to release the pressure with the P technique, you will not be able to do that. So the question is always the same: are we treating the aesthetic problem, or do we want to release the raised ICP? Do we want to release the sagittal sinus from the bone?
Okay, no, thanks, Federico. It's a really insightful answer. John, you want to read the question from, is it R. Avarti Sankal?
Yes, of course. Yeah, we have a question from Sankal Avanti, a resident from Bangalore, India. He asks, how long should you continue the anti-epileptics?
We don't use at all anti-epileptics.
Okay.
So if there is no cortical problem, if there is no previous history of anti-epileptics, of epilepsy, there is no need of anti-epileptics.
Thank you.
Okay, James, some comments before you commence your talk. Maybe just a few comments on Federico.
Yeah, no, I mean, I think I would very much agree. You know, there's no role for anti-epileptics in surgery, at least in our center. And in general, I agree very much with Federico's points about that management of craniosynostosis, that each child is a little bit different, and that you should be able to use a variety of different techniques to treat them, because they all have advantages and disadvantages. So unfortunately, there will not be major disagreements between me and Dr. DeRocco for this particular presentation.
Okay, thanks so much, James. So I've got, maybe just in the interest of kind of time usage, just two kind of logistic questions. So a lot of centers in Africa would have just a pediatric neurosurgeon, or maybe just a plastic surgeon, you know, if you're lucky. So I agree completely with the MDT approach. I think one needs to do that in a center that does high volumes. But what would you suggest to and there are a few of them on the call, you know, a relatively young pediatric neurosurgeon faced with a kid who has, let's say, plagioccephaly, frontal plagioccephaly. I mean, would you suggest that they do it on their own, or would you suggest they refer out to another center?
Well, it's very difficult to answer, because it depends on where is the other center, depends which type of volumes they represent, and what type of results they want to reach. What is to be understood is that in type 3, for example, plagiocephalus, the results will not be excellent from the aesthetic point of view. In a type 1, you can reach better results. So it really depends on the setting you are and how you can deal with your bad results. From my point of view, if you are dealing with a type 3, which will be aesthetically not very good, at a certain point, the child will be seen by a plastic surgeon. So the earlier it is seen, the better it is for the management. What you want to avoid is that you do a surgery in a very young one, and then age 4, somebody else see the child and say, oh, what did they do? It was not the right way to do the surgery, and then you will get in trouble. So it really depends on the type of surgery you are dealing with. For scephocephaly, there is no need of plastic surgeon or maxillofacial. Most of the cases of trigonocephaly, you can reach very good results. In type 1 plagiocephalus, you can reach good results. In lambdoid synostosis, very good results on your own without plastic surgeon or craniofacial surgeon. The complex cases or the severe plagiocephaly, they will have aesthetic issue, they will have maxillofacial issue, and in those cases, the better it is to involve the maxillofacial surgeon very early. And the collaboration will improve the management for the future.
Thanks so much, Federico. So Mo, I'm going to hand over to you to introduce our next speaker.
Okay, thanks, Federico, again, and thanks for the discussion. So we'll move to next speaker is Professor Dr. James Johnston. James is an associate professor in the pediatric division of the UAB Department of Neurosurgery. He practiced at the Children's Hospital of Alabama and is the medical director of the Global Surgery Program at Children's Hospital of Alabama. Dr. Johnston received his MD degree from the Washington University School of Medicine in St. Louis, and he completed internship in general surgery at the Washington University at the same place. Dr. Johnston practice include all aspects of patients' care related to neurological surgery in children, including brain and spine tumors, gamma knife radiosurgery, neurocritical care and trauma, craniosynostosis and vascular pediatric neurosurgery, congenital disorders. He's a board certified by the American Board of Neurosurgical Society and also a board certified by the Pediatric Neurological Surgeons. He's a member of the Congress of Neurological Surgeons, American Association of Neurological Surgery, Society of Neuroscience, Pediatric Neurocritical Care, and the ISPN, American Society of Pediatric Neurosurgeons, and the Children's Oncology Group. Actually, we are doing a great collaboration with Dr. Johnston and the team of the oncology, Girish Dal, with our hospital at the Children's Cancer Hospital in Egypt, together with the Alabama group, and it's really a fruitful collaboration. Thanks, Johnston, for accepting our invitation and looking forward for your presentation.
Well, thank you very much, Mohammed. It's a real honor and privilege to be invited to speak before this group, and especially to follow Dr. DeRocco talking about craniofacial surgery. Obviously, the whole world has learned from his experience and his group's experience at Necker, and it's a real privilege to talk a little bit about craniofacial surgery with you. What I'm going to talk about today is a little bit more, let's see here, practical in terms of surgical strategies and complication avoidance in craniofacial surgery. So this talk is primarily about open treatment of craniofacial surgery with its various types. At our center, just like with Dr. DeRocco, we about 50% of our cases now are endoscopic and minimally invasive techniques, but a lot of the principles that I'm going to talk about today, I think, are very useful for any craniofacial surgeon, especially in their early years as they get going, building a practice either by themselves or with a plastic surgeon working with them. So, as an American neurosurgeon, Harvey Cushing is our saint. And it's important to remember that the reason why he was able to develop neurosurgery based on a very fastidious technique and attention to detail that surgeons before him were not doing, and that's what led to his early successes. And so, craniofacial surgery, of course, was founded by Paul Tessier in France, who did incredible work in terms of understanding of the facial skeleton and manipulation surgically in order to correct deformities that before that were not able to be corrected. But it's important to remember too that his neurosurgery colleague Gerard Guillot played a very important role in making some of the designs of surgery and actually implementing them so that these surgeries could be done safely in such a way. And literally the techniques that they pioneered are similar to what we do even now. So I'm a big racing fan, Formula One racing fan. And so the way that I think about it is that complications in craniofacial surgery are neurosurgical complications. And our job as the neurosurgeon, whether we're working by ourselves or if we're working with a plastic surgeon, is to provide a race car that is running perfectly so that the driver can solve the problem that he wants to solve. And that is a combination of things like efficiency, of surgery, precision of surgery, and probably even more importantly, reproducibility, so that the rate of complications and risks is so low that we can justify doing these procedures again and again and again in a safe way. And so I think about aviation with the Six Sigma concept, where, you know, again, the complications that we see in craniofacial surgery are relatively low, but when you look in the literature, they're definitely not, you know, as low as in aviation. And we see rates of major blood loss and up to 4.5%, infection, dural tears, air embolus, and even death, especially in earlier series. Whereas those rates of complications that you see in aviation are much, much lower. We're talking about 0.0004% complication rate. So the question we have to ask is, how do we go about doing these procedures in a way that we can bring our complication rates so low that the surgery can be as safe as it possibly can be? So like Dr. DeRocco talked about previously, it's very important to evaluate the patient, because different patients are going to present different levels of risk. And the preoperative evaluation is incredibly important as part of this. So first of all, you have to determine whether a child is syndromic or non-syndromic. Children who are non-syndromic with an isolated sagittal suture, synestosis, for example, are much, much lower risk and less complicated than patients who are syndromic. And Dr. DeRocco did a masterful job of reviewing the complex genetics and multiple syndromes that can be associated with craniosynostosis. And these are things that you're going to pick up during your physical exam, talking with the family history, you know, talking with their relatives. And in these more complicated cases, we typically in our center will do a 3D CT scan. Again, we don't do CT scans on our non-syndromic patients, but in a child that we have concerns about syndromic or multi-suture synostosis, they'll get a 3D CT, and oftentimes at least a rapid MRI scan. And the MRI scan is there to evaluate for those things like hydrocephalus, Chiari malformation, and vascular anomalies that can make your surgical intervention and surgical planning more complicated. So like was mentioned before, ideally, these children are evaluated in a multidisciplinary setting because many times these children can have issues with airway compromise, cardiac anomalies, papilledema, corneal exposure, facial clefts, GI abnormalities, hearing loss, intellectual disability, and congenital limb abnormalities. But for our purposes today, I'm going to talk about intracranial anomalies, because those are things that are going to really be important for you when you're planning your surgery and actually doing your surgery. So hydrocephalus is something that has to be evaluated early and determined early. And in our experience, we have found that, like was mentioned earlier by Dr. DeRocco, in children who have multi-suture, children who have multi-suture synostosis can have the development of hydrocephalus, especially in the first several months after birth. They have to be followed closely. And what we have found is that when you can find the hydrocephalus early, when the hydrocephalus is just starting, that interventions like posterior vault expansion, where you're changing the volume of the cranial vault, can be very, very effective and let you avoid put in a shunt or do an ETV. Although, like Dr. DeRocco mentioned, sometimes that's not an option. Sometimes children will present later with more severe hydrocephalus, and that will need to be treated typically with a shunt. Our experience with ETV has not been as good for treatment of these children, probably because they have a level of elevated venous tone and CSF absorption is not normal. But in these cases, those children do need to be shunted. But again, if it is a mild case of hydrocephalus, early stages of hydrocephalus, a lot of times you can intervene with some sort of posterior vault distraction to avoid needing to put in a shunt. Chiari malformation can be seen, especially in children who have multi-suture synostosis. The first question that has to be asked is this a symptomatic Chiari malformation? And this can be determined by physical exam, sleep studies, swallow evaluation, and looking for clinical evidence of brainstem compression. Similarly to hydrocephalus, oftentimes this Chiari can be treated indirectly with some sort of distraction procedure as opposed to a true Chiari decompression. We do have children who have Chiari malformations who never require any sort of treatment beyond the treatment of their craniofacial surgery. I know that some centers are much more aggressive about treatment of Chiaris, but in our center, we found we're relatively conservative with direct decompression of Chiari malformation. And finally, vascular anomalies. Sometimes these children especially with multi-suture synostosis, can have anomalous venous drainage, which can lead to elevated intracranial venous pressure and even sinus pericranii, typically at the torcula. And our management for these children, when we do find them, has been posterior vault expansion. Again, kind of staying away from the direct area of the sinus pericranii, and doing an indirect expansion can be quite effective. This is a child, a 6-month-old with Crouzons that we treated several years ago, who presented relatively rapidly with development of early hydrocephalus and this very prominent sinus pericranii. We did a posterior vault distraction, unlike the standard posterior vault distraction, where the distractors are placed laterally, we actually placed the distractors more paramedian with a barn door type approach here. Over several months, just like Dr. DeRocco was talking about, allowed the distraction to take place, allowed for consolidation. They were removed and actually had spontaneous resolution of the sinus pericranii. Then when the child was a little bit older, around 9 months of age, underwent frontal orbital advancement, and has done very, very well from this, this sort of staged procedure, with never requiring a shunt or any other vascular intervention. So again, if you can change the volume in a safe way, that tends to treat some of these vascular anomalies that you can see. Finally, early intervention, we have to say something special about those children that are born with true pan-synostosis and cloverleaf. These children can be very difficult because you have to intervene quite early, because they have they develop progressive hydrocephalus and elevated intracranial pressure. The options for this are somewhat difficult and have to be somewhat tailored. We early on did many more endoscopic release type procedures of the sutures, but we found that was not as useful because, like Dr. DeRocco mentioned earlier, many times these children actually have a bone growth issue. And so just releasing the sutures does not necessarily give them a very definitive treatment for their early pansynostosis. And so again, with these children, we have moved towards a posterior cranial vault expansion, either with springs, which are left internally, or an external distractor. This is an example I found just from several months ago in a child who has Apert syndrome and has a bicoronal craniosynostosis, but has a true Hydrocephalus, acting more like a pansynostosis type picture, had early development of ventricular enlargement and evidence of elevated intracranial pressure. And so in this case, what we did was a posterior vault distraction, again with standard distractors over several months, and then did bilateral releases of the coronal sutures and placement of internal dwelling springs. And this child has actually done very, very well. And this has sort of become our new method of management of these children, because of being able to walk the line between a maximally invasive procedure and a less invasive procedure, but allows you to do some element of distraction and avoid early large cover vault surgeries when the children are so young. So operative principles, again, once you have decided on your operation for a child, there are some basic operative principles which I think are very important. First of all, you want to avoid CSF leak, because CSF leak is the biggest issue that can lead to further complications. I've found that burr hole placement or access to the dura is very, very important. Even in younger children, you want to make sure that you are strategic about where you place your burr holes, careful to stay off the midline, and off of abnormal sphenoid dysplasia or other things, especially in a unicoronal craniosynostosis or bicoronal craniosynostosis. The technique, you have to be careful. You want to avoid burning the dura. The dura on very small children is quite sensitive, and even the removal of the bone, the heat that's generated by the drill can lead to a partial burn and delamination of the dura. And so you have to be very careful about this both by not drilling for too long, and also using irrigation to keep the end of the drill quite cool. This is an older child, around 6 months of age, for our open repair of sagittal synostoses. The circles I put there are areas where we typically use to place our burr holes, which allow us, as you can see, they're paramedian, and allow us to connect our other cuts for our calvarivalt reconstruction and minimize the risk of injury to the underlying dura. Sometimes, especially in multi-suture synostosis children, you'll actually do several small burr holes and actually connect them with either a Kerrison punch or, like what Dr. DeRocco was talking about, some kind of a oscillating bone saw to minimize injury to already quite thin dura in these children that can have copper beaten type skull and more difficult to cut bone. Frontal lobe advancement burr holes are similar. We have moved to an asymmetric two-piece frontal bone flap to avoid some of those veins that Dr. DeRocco talked about earlier, because our plastic surgeons tend to split that frontal bone anyway when they do the reconstruction, and this allows you to make your burr holes on either side of the midline, and basically as you remove the bone, able to directly see the sagittal suture or sagittal sinus, and then down to where those emissary veins are to directly control them and minimize any sort of bleeding from the bone flap removal. Dural stripping and protection is very important. There are many different ways to do this, and all of us have our own preferences. I use a combination of curettes and Penfield dissectors, sometimes use a Kerrison punch, like I said, when there's a very thin dura or the dura, or very thin dura or very thin bone where the dura is actually involuted inside the bone, again, to minimize any tears of the dura and CSF leak. Protection of the anterior cranial fossa dura is very important. That dura there anteriorly, when you're doing frontal lobe advancement, is quite thin, and it's very easy to tear when you're dissecting it away from the anterior cranial fossa floor. And it's also very difficult to repair because it doesn't like to hold a suture. So our techniques when we work with our plastic surgeons is to do a 2 or 3 person technique where someone is protecting the dura while the plastic surgeon is making the bone cuts through the nasofrontal suture and through the frontal roofs. And finally, if you do get a dural laceration, you want to have a couple things in your tool chest about how to fix them. We tend to use pericranial grafts that are harvested from pericranium. We don't use any synthetic materials. Most of the time, if it's a very simple laceration of the dura, you can close it with just a primary repair, but sometimes, especially in small children, the dura is quite thin and is difficult to repair primarily. We have adopted a gasket technique where the pericranium is basically sewn so that it overlaps on the subdural space of the dura, and then uses the brain pressure itself and CSF pressure to seal off the opening, just like a gasket, like in an engine or something like that. We found that to work better than just onlay a graft that's tacked down. So avoiding infection, whatever protocols your hospital use, you want to be quite fastidious with them in terms of scalp preparation. We use perioperative antibiotics. Temperature regulation is important. You don't want to let the children to get too cool, as it's been shown, especially in younger children, to increase risk of infection. You want to avoid dural tears and CSF leak, like I just talked about. Rigid bone fixation is very important, whether that's with absorbable plates or stainless steel wires or whatever it is that you or your plastic surgeon prefers. If you do get into the frontal sinus, this is more of an issue with older children, especially in trauma. You want to make sure that that sinus is completely cranialized and sealed off from the intradural or intracranial compartment, typically with autologous pericranial graft. Again, this is a much more important for trauma type surgery, but again, this is a very good skill set to have with harvest of the pericranium, typically as a second step after you've elevated the scalp flap, and then being able to lay it into the anterior cranial fossa with a parachute type technique where you can tack up the corners to the more posterior underlying dura in the frontal lobe to keep it in place and then give you a nice vascularized graft that seals you off from your sinuses. Bleeding is obviously an important consideration, especially in younger children. A TXA is used by many centers, and some centers have demonstrated some improvement in their levels of blood loss and need for transfusion with it. I tend to emphasize efficiency and use of technique that minimizes bleeding with the scalp flap, with the elevation of the pericranium or leaving the pericranium down, like we typically do with our normal synostosis cases. Using multiple burr holes off the midline to minimize any risk of injury to the sagittal sinus. Waxing of bone edges when necessary, use of suction bovie, especially in endoscopic procedures. Like I said, we've moved to a 2-piece bifrontal craniotomy, which allows us to control the bleeding from those emissary veins in the anterior cranial fossa. Again, this sort of gives you a picture of that sort of 2-piece technique where we will typically elevate one side and then under direct visualization, dissect off the sagittal sinus and then directly see those emissary veins and control them with a bipolar. It's a video of sort of that technique where once you've taken off one side of the frontal bone flap, it gives you a very nice visualization and able to work down towards where those sinuses, where those emissary veins are, and then really taking your time when you're dissecting the dura away from the anterior cranial fossa, from the sphenoid wing, especially when you have a duplicated sphenoid wing or other abnormality in your unicoronal craniosynostosis, and down into the middle cranial fossa. This move is very, very important and was one of the most important things that Dr. Guillot contributed to the craniofacial surgery techniques of Dr. Tessier in terms of protecting the temporal lobe and avoiding dural laceration or temporal lobe injury. Air embolus is a quite rare possibility in craniofacial surgery. However, we always have to be aware of it. The diagnosis of this, typically your anesthesiologist will notice a rapid drop in end tidal CO2 and hypotension. Management is a rapid flooding of the field with irrigation, dropping the head below the heart, covering the bone and the sinus with wet sponges, and if necessary, if you have a central venous catheter, aspiration of the air bubble from the right atrium. So management of sagittal sinus bleeding. So first of all, the best thing to do is to avoid sinus injury in the first place. And typically sinus injuries, when they happen, are rare, but when they are, they tend to happen due to inadequate burr hole and stripping across the midline, typically in children with multi-suture synostosis, or especially in children who've already had prior craniosynostosis surgery and you're going to go back to do a secondary procedure. It's very important to make your burr holes off the midline, use your stripping technique. And if you're going to use a foot plate, make sure that the underlying dura is completely stripped away and that you're able to see that the sinus is not involuted into the bone itself. And one concept that was taught to me by a senior neurosurgeon is no matter how bad things are, you can always make them worse. So sometimes surgeons will panic. They start to see bleeding from a large venous sinus. They'll get a bipolar or start to try put a stitch in it or try to do other things, and that only makes the opening worse. So one thing you can do, first of all, is put some gel foam patties, put pressure on it, and that typically will definitely stop the torrential bleeding that can happen. If you have bone that's adjacent to where your sinus is, you can put in some dural tack-ups and then tack up the dura up against the bone with some bit of gel foam over the rent in the sinus, and that can be very effective for controlling sinus bleeding. Remember, the anterior third of the sinus can be ligated with acceptable risk, especially in younger children if necessary. And if you cannot control it with any of these things, the dural fold-over technique is a very nice technique to control the bleeding. In my experience in children, I have not had any significant sinus injuries that required sewing on the sinus, but my understanding is from senior neurosurgeons that trying to sew on a pediatric sagittal sinus is not a very useful technique. And so this is a very nice video. I urge you to go see. It's on the Neurosurgical Atlas by Dr. Aaron Cohen-Goodall. These are just some snapshots from there, but basically the first concept is if you have a sagittal sinus injury, to compress on either side of it, because that will decrease the amount of bleeding that you're going to have from it. Then you can elevate with your insistent holding pressure on either side of the sinus. You can elevate a small bit of dura around it on one side of the normal appearing dura. Then you can flap it over the hole with a piece of gel foam in the hole and then sew that down to the contralateral dura. And that can act as to hold pressure for you and typically will be enough to control the injury to the sinus. Again, first rule is avoid sagittal sinus injury. Post-operative management is also quite important. Like Dr. DeRocco mentioned, the number one thing we have to worry about is bleeding in these children. So close follow-up of hemodynamic status during surgery, immediately after surgery, and in the hours following surgery are very important. Looking at heart rate, children who become very tachycardic and then normalize, especially in the setting of low blood pressure, you know that they are getting ready to have a hemodynamic crash in terms of hemodynamic shock. Blood pressure is a very important parameter to follow. and looking at subgaleal blood and JP drain output. If a nurse calls you and says that there's blood coming out of your suture line with a significant amount of blood in the subgaleal space, that is something to take very seriously. In our center, we tend to check hematocrit right immediately post-op and then 4 hours afterwards. And if that's okay, we'll follow it again the following morning. Our transfusion rules are less than 24 for an open procedure. We tend to transfuse because we know they're going to continue to bleed from their bony cuts and scalp. And an endoscopic procedure, we wait until they're less than 19 before we transfuse, because typically they don't have significant bleeding after surgery. CSF leak, again, try to repair it during surgery. If you notice that you have clear fluid in your Jackson Pratt bulb, you want to take it off suction, make sure the head of bed is at 30 degrees. And typically that will resolve any leak. Rarely you would have to place a lumbar drain or go back to repair it with open surgery, although fortunately that is quite rare necessity, especially when you follow these principles. Infection, again, is quite rare, especially in single suture synestosis. It's more commonly seen in more complex synestosis, multiple procedures, especially in children who've had prior distractors. It seems to be a slightly increased risk for infection. In our experience, in those rare cases, we'll take them back to the operating room, do an extensive washout with drain placement and antibiotics, and we have not felt it necessary to remove the bone. Typically, the bone is vascularized enough that with the underlying dura, et cetera, that you do not need to remove it. So again, this is an important effort that requires both the driver, the plastic surgeon, and the reconstruction portion of the procedure, as well as the engineer who can provide the car that's not leaking oil all over the track. I know that this past year, that's probably better for me to also put Lewis Hamilton and Toto up as well. But again, the concept is the same, that all of this requires careful attention to detail to provide the best possible race car for the best possible result. Before I get off, I just want to put a special plug in for Intersurgeon. For those of you who are not familiar with it, this is a free service that's available. There are more than 800 members on it. As a social network for global surgeons, not just in neurosurgery, but all surgical subspecialties. It's free to join. You can create a profile and you can join, make offers and requests to connect with surgeons around the world for collaborations in clinical training, research, and things like this. Thank you very much. Merci. And I'm happy to answer any questions that you all may have.
Thank you, James, for this nice presentation. Actually, a wonderful presentation with many hints and important notes. I think there is a question on the panel from Dr. Assam Al-Gamal, is a pediatric neurosurgeon in Abu Dhabi in United Arab Emirates. He's asking, what do you do for 12 months old child with non-syndromatic sagittal synestosis without any brain anomalies and found to have a bilateral papilledema?
Yeah, so I think that age, like Dr. DeRocco, our center would consider that patient would be for an open Calvera vault reconstruction procedure for the sagittal synestosis. We only provide endoscopic, minimally invasive approaches for children about 3 to 4 months of age. At our center, we do helmets, but we also place springs, and that's because in Alabama, our insurance system will not cover helmets, so we actually provide springs for those children. It works quite well. So that's another discussion. But for a 12-month-old child, we would consider that too old for endoscopic procedure. We would do an open Calvera vault reconstruction. Either one of our plastic surgeons uses resorbable plates. One of our other surgeons has moved back towards wiring technique. Neither of them uses a pie technique. They use a Calvera vault reconstruction, and that's how we would manage that.
Okay, so I have also another question. Yeah.
May I just comment? I completely agree
Yes,
with
please.
James. You need to do if you want to do surgery, you need to do a proper one. So the first step is the papilledema. Is it related to the synostosis or not? Because it's not so common to have papilledema at 12 months of age. So first of all, you have to rule out any other etiology for the papilledema. Once you know that papilledema is clearly related to a problem of the pressure, then you need to decide which type of surgery. Why I insist is because you have papilledema in a scafocephaly. Sometimes it's a cruzone, sometimes it's another problem. So you really need to be sure what you're dealing with again. Then, if you decide to do the surgery because you want to treat the papillary edema, you need to do a large and immediate remodeling. The principle of the endoscopic and helmet is that the change in volumes, the change in shape will take some time. You have a papillary edema, you don't have time. You really want an immediate change in the pressure. So again, this is another strong argument for immediate releasing with a complete remodeling. And while you are there doing your bicoronal synostosis, then you will adapt your type of surgery to the type of deformation. If it is more affecting the posterior part, the middle part, or the anterior part, because at 12 months of age, if the forehead is very prominent, it will not go back if you just do operator release. So you have to adapt your surgery to the deformation. As it was said by James, he's just saying the same thing in another way.
Yeah, okay, thanks. So I asked John if he can unmute Sam Al-Gamal if he wants to comment on his question.
Yeah, just admitted him. Bello has a question, I believe, or a
Yes,
comment.
please, Bello, yeah.
Thank you, James. Thank you very much. I just need to know what percentage of your patients do you transfuse intraoperatively? I see you have a very strategy of complication avoidance, especially bleeding, which is a major issue, especially in our settings in Africa. So what percentage of your own patients do you transfuse intraoperatively?
Yeah. So I would say that our center is quite aggressive with transfusion therapy. We are greater than 90% of our children open procedures will get a blood transfusion. I know that some centers in North America are much more aggressive with not transfusing with various techniques, but our center is, I would say it's definitely greater than 90%. Endoscopic procedures, it's about 5% or so. Typically older, thicker skulled children, but yeah, most of our children get transfusion.
I'm very relieved to hear that. I thought it was going to be much lower. In that case, I was guilty because I thought then the technology would have reduced, except for the endoscopy. But thank you very much.
What strategy, you can use, yeah.
I'm interested in Dr. Duroco's experience.
TXA.
Though,
it's a TXA, tranexamic acid. And what we use also in children is we use a preparation with erythropoietin before surgery in order to increase their blood volume and hematocrit. So, but at the end, even with that type of preparation for the older children, as you mentioned, for the older scapho or trigonals, the transfusions rate is 80%. But again, it depends on where you put your security threshold, because the lower you go, you can go down to accept 8 for hemoglobin, but then you might have some children that have a low brain perfusion. So it really depends on where you put your safety. The fact that you transfuse them is not that you did a bad surgery. This is a common confusion, because we consider transfusions like a proxy of a bad surgery, and assuming that a good surgeon has no transfusion and a bad surgeon has transfusion. The child, by definition, does his blood with the bone. So it's the bony element that produce blood. So there will be blood loss, and there will be blood loss continuous. So the problem will be if you don't recognize them, and then you have a functional problem.
I believe Assam has a comment. Assam El Gamal, do you have a question or comment?
Yeah, thank you for your thoughts about this child with papillary edema. Although it is uncommon to see papillary edema in a sagittal suture, simple synestosis. We have discussed this case with the ophthalmologist and pediatric neurologist to try to find a reason for his papillary edema. Is it local in the eye or idiopathic intracranial hypertension? We suggested even lumbar puncture, but we couldn't find any reason for his papillary edema, and everybody is actually in favor of doing the sagittal suturectomies, multiple biparietal osteotomies to decompress the brain, and we can help his papillary edema with some medical treatment as well.
It's clearly something that you can do. The other thing is that you can have a drusen type of modification at the level of the eye. in that you need a fluoroscope and fluorescein examination to distinguish from the real papillary edema. So this is an ophthalmological problem. You need to do the right discussion because you can have a drusen type modification. But again, in case you don't know to distinguish, you can either try and see if Diamox will change something, because if it's a real ICP problem, with your diuretics, you can change the papillary edema, the drusen will remain the same. But then again, if there is a deformation, if there is a high risk of having a papillary edema, it's easier to do the surgery, and then you are, But again, there is a small chance. If there are drusen, you will have the same examination just after the surgery. There will be no change in papillary edema. So you have to prepare also the family that you might have this differential diagnosis, and then the papillary edema will stay the same, but there will be no evolution to the visual loss.
Thank you. Thank you very much.
Okay, I have another question, which is for James and Federico. What if you have an overcorrection of the bone done, bony work for the surgery, during the surgery, and still after the age of 1 year and 6 months, you didn't get this bone fused? So
are you talking about like a frontal orbital advancement that it's over corrected and just not fusing, or?
Yes.
But you're talking about a bone defect or a bone?
No, if you do a cranial synestosis for a sagittal single suture synestosis and you did the surgery without a helmet at the age of 6 months, because I have had a case like this, and then it is reaching almost 1 year and 3 months, and the bone is not all closed, so still you have defects in the.
Defect is something that you have to accept.
Yeah, I would watch. Yeah.
So defect is common. It's not. The older you operate, the higher the risk of defects. If you operate after 6 or 7 months, defects are very common. It's 10% of your cases. Then it depends on the size and location of the defect. This is why after 6 months you have to place some piece of bones to do like harvesting, and that you put there to have some bone graft from the patient in the strategical places in order to be sure that there is a reduced risk for the child later on. So if the defect is larger than 2 centimeters over a venous structure, or after 5 to 6 years after your surgery, you can discuss doing a cranioplastic, like splitting the bone and closing the defect. If the defect
so
is
you
small,
wait till what age until doing a cranioplasty?
Depends on the size of the defect, and then depends on the location. If the defect is over the sagittal sinus and is large, like 2 centimeters diameter, large over the sagittal sinus, you are a little worried. If it is 1 centimeter on the side, on the coronal suture, you don't care.
Sorry, just one moment again. You spoke about petrous osteoporosis. What do you do for that? I really didn't get it. I don't do anything.
It's a genetic condition which has an increase of bone from in all dimensions. So that will lead to blindness, raised ICP, Chiari, and other things. So what you need is you have to change the bone marrow. It's a bone marrow transplantation. It's an oncological problem. You need to do, if there is a donor, and if it's you will ask your oncologist, but there are several types of osteopetrosis depending on the gene. So some of them respond to bone marrow transplantation, other less well. If you have the chance to have the good gene, you can do a bone marrow transplantation, and then you treat the synostosis. It's easier to treat the synostosis and the problem of the narrow optic canal after the bone marrow transplantation, because your surgery will be almost normal, because it will be abnormal thickness but normal bone. If you do the surgery before, there is a higher risk of bleeding, higher risk of complication. So it really depends on the optic status.
So the diagnosis is both genetic and
clinical. Yes, it's clinical on the radiology because your bone thickness is abnormal.
Right.
And then you have a confirmation by the genetic anomaly.
Right. Thank you very much.
You're welcome.
So any more questions? John, do you have any questions on the?
There was a question that came across by Mariella Infante, and is the child's age a contraindication for endoscopic treatment of cranial synostosis? And yeah, so typically our center and most centers will treat endoscopic. It's 3 to 4 months of age is the time to do that procedure. After that, it becomes less useful, or you can't do it. So.
She has also another question, which is, how often have you observed papilledema in complex cranial synostosis?
Well, typically, if they're born with a complex cranial synostosis, and we don't want to let it get to that point where they get papilledema, rarely you will have a child that will present later who has multi-suture synostosis typically with some symptoms, headaches, changes in their cognitive things that if they're a little bit older. And they were not diagnosed, and they will have papilledema. That's very common. So,
yeah, it's really if we go back to the discussion about transfusion, transfusion is not an issue. If you transfuse, it's not a problem, but is discussed by the surgeon. But it is not important for the child, and doesn't mean that your surgery was not done correctly. If you have a papilledema and complex cranial synostosis, this raises the question about your general management, why the child is arrived at that stage, because there was at some point something was missed. Either the early diagnosis was missed and the child comes to you, he is age 4 and he has a Cruzon with papilledema. This means that the pediatrician and other doctors missed the diagnosis of Cruzon, or there is something going wrong with the shunt or with the hydrocephalus in general that you missed during your follow-up. So again, as James said, ideally it should be none. But it's common. As I show you the figures, it is 40% or 60% of the complex synostosis that will have raised ICP at a certain point.
Rodrigo, what's the reason for the failure of ETB?
Because it's a mixed origin of hydrocephalus. There is a problem, as I said, of venous engorgement and the venous stenosis of the jugular foramina, and there is a problem of the anatomy with the small posterior fossa and indirect modification on the aqueduct. So if the main issue is that there is a small posterior fossa and an aqueduct which is distorted, you do an ETV and you solve the gradient of pressure. If there is a kind of a Chiari that plays an important role, as in Chiari and hydrocephalus, ETV can solve sometimes the problem of the circulation because it gives a different pattern to the CSF. If the problem is the brain compression and the jugular vein compression, ETV will not solve the resorption. This is why when we did our series, we selected patients with anatomical distortion. Even in the anatomical one, the results were 50% of good response. So even in those in which we thought that it was a gradient, it was not the only mechanism, and they still needed a shunt.
And how is important is the ICP monitoring post-operatively? Do you do it in all the patients, or
no? No, ICP monitoring is really for selected cases to make a diagnosis in older children in which you hesitate, I do surgery or not. If you have a concomitant symptomatology, the child complains of headaches, he has a fundus with papilledema, he has a synostosis, you don't need to do a hole in the brain. It's easier to do the cut in the bone. Because from my point of view, the invasive, ICP monitoring is more invasive than doing a flap of the parietal bone. Even if the scar is larger, you don't want to touch the brain.
Yeah, I would agree with Dr. DeRocco. It speaks to the importance of these children, following them over time, because there is we in our clinic, we tend to follow them till the early teen years. And basically, there is a small risk in even single suture synostosis of them requiring a follow-up procedure for expansion. It's a couple percent, 1 or 2%. But children who have syndromic synostosis, multi-suture synostosis, it's much higher than that. So those children need to be followed. And like Dr. Rocco said, if you have a child that has new symptoms, headaches, other issues, and they have papilledema, obviously you intervene. If they don't have papilledema and you're concerned that their pressures are high but not high enough to cause the papilledema, you can do an ICP monitor. But in those kids, you know, it would require some sort of intervention.
And the ICP will not answer all your question, because you will have a snapshot of the ICP in one specific moment in a child who is at the hospital, not doing his everyday activities. So all the question will remain unsolved. So it is very rare we use nowadays ICP monitoring for these kids. But again, I want to stress the importance of the follow-up, because as I said, in a minority of cases, depending on the volume you have, you will have other disease that will come over. You will have problems. So depending on how you're organized, you have two main strategies. One is that you do all the analysis at the beginning. The child comes and you have a genetic panel, you have a karyotype, you have whatever you want to have, in order to be sure that it's not a genetic anomaly, there is not a trigonal with monosomal chromosomal anomalies and so on. Or you do the surgery and you wait and you follow these patients, because if their development is not perfect, you will need to find why it is not perfect. And again, you will see that some of them have a mutation or a problem. So you have to ask all the questions about the cognitive development, but also the bony development. You need to check when the teeth will come. You need to see that the legs are straight and so on, because some of them might have hypophosphatasia with abscess, the dental abscess and the leg bone. So, but you will know that only later. So in my practice and with my patients and with my setting, it's much easier to do all examination at the beginning. So I can say, oh, there is a mutation in HPP gene, so he will have problems with bone. It's better we start studying that with the expert of hypophosphatasia immediately. Or, oh, there is a chromosomal anomaly, he will have cognitive problems. Because when you do the other way around, the parents will always remain with, oh, it was perfect until the surgery, and then after the surgery, he has a mental delay. No, the chromosome was not there since the beginning. We didn't cut the chromosome with the surgery, but it's more complex to explain, and the family will remain with the idea it was perfect until the surgery. So this is why we prefer to do all these examinations before, but they're really expensive.
James,
Okay,
what is
so
the genetic in the US? James?
Yes. What'd you say? I didn't hear that.
I said, what is your experience with the genetic studies as a backup to the cranial synestosis? How
like Dr. DeRocco, I mean, we have a geneticist who comes to our clinics who will help investigate when they're we do genetic evaluation on every child with any sort of suspicion of family history or multi-suture synestosis or et cetera. We don't do genetic testing on every single, like for example, if it's a simple sagittal synestosis, we don't do it necessarily on every single one, although I would tell you that we're getting more aggressive about doing testing everyone. That case that Dr. DeRocco said about missing the Sensenbrenner, oh my gosh, it gave me palpitations thinking, I wonder if I've missed any Sensenbrenners in my practice. But yeah, we do have a geneticist to check children who are obviously syndromic.
The problem of Sensenbrenner is that it's tricky because it's a mild syndactyly that you see at birth. Then you have the teeth problem, enamel problems that occur later. But most of the cases, we do surgery at 3 months. There is no teeth. It's already the beginning. Yeah. So, and then it's not a question you ask systematically. Is there a problem? Did the teeth appear? Are they normal? And so on. Mm-hmm. So in some cases, the parents, for them, it's normal not to have teeth at age 1. They don't care. They don't tell you, and then it's done.
Yeah.
So you need to ask the good question if you want to have the answers.
This is very interesting because back here, we thought with the facial maxillary surgeons and the little pediatric neurosurgery we do, we have answered the question. But just now we have raised a very difficult area for us to get the geneticists who will back us up, because I think it's really very important that you get all the answers before the surgery, like you said, so that the parents
You will have problems. I mean, the genetic anomalies, when you follow systematically, we are publishing I'm sorry, the paper is not out yet, but it's around 10%. So if you do 100 midline synostosis, K-von trigonons, and so on, you will find something in 10%. This something is not always pathological, but still there is something in 10 and probably pathological in 5 or 6, which explains you also how difficult it is to analyze the results of the studies that have been done in the 80s and 90s on the cognitive outcome of these children. Because if you have, as you will see if you search for SMAD6, SMAD6 is a gene that can give you several types of synostosis, but it does also cognitive problems later on. So if you're in your group of patients, you have 2 or 3 SMAD6, your results will be poorer due to the gene and not to the technique and surgery and so on. So this is something that you have to remember, just to explain to the parents that you normalize the growth of the bone, but what happens to the brain is independent and depends on several factors that the time will see. By definition, we don't know at what age the child will walk, at what age he will speak, and what will be the results at school. And will it be independent? Probably from what you do of your surgery. But if you don't do surgery, it will be worse.
Thank you.
Okay. Any more questions, Bello?
Thank you, Mohammed. This is great. Thanks very much.
Oh, thanks. I just want to have a comment. If the first presentation was pale disc and not papilledema, which we passed already the papilledema, could you still follow up the fundus by a visual evoked potential instead?
No, now what we do is OCT. We do a CT scan.
Yeah.
Yeah, we use more OCT than evoked potential.
Okay. Llewellyn, you have any questions or comments?
No, thanks. That was a really fantastic discussion. I mean, we covered so much more than we originally intended to, but that's just the nature of these sorts of talks.
Okay.
I see there's a question from Wen Firehawk.
There's one
question, Wen, and then we'll.
There's one question in the chat also about the bone wax complication. Yes, there are bone wax complications if you put too much and you don't remove it. It will make a granuloma.
Sorry. So Gwen, you want to ask a question?
Yes. Hi everyone. And
Welcome.
I'm a I'm a Dr. Học from the Vietnam, from the Vietnam National Cancer Hospital. So
we can hear you. I have one question for you. What time is it in Vietnam?
So you know, in infection post-operation in a big problem in the development country like Vietnam, and I always scared about the infection, especially about the inflammation bone, and combined with the muscle in the outside of dura. And you know, many cases with treatment with antibiotic, with antibiotic diagram negative, and which only treatment by antibiotics is a long time, and to many cycle antibiotics is still many fruits from the wound. So I want to when you share experience about the treatment that case, if I will concern about the focus on the Dr. Johnston focus about the don't necessary to remove the bone when the infection wound post operation.
Yeah, so typically what we found is, so first of all of our patients are on some antibiotic during surgery, after surgery, when we have the drains in place. And then once the drains come out, we turn off the antibiotic. We use cefazolin, so it's a 3rd generation cephalosporin. If they do get an infection, we're very aggressive about taking them back to the operating room, opening up the incision, washing very, very aggressively with antibiotic irrigation. bacitracin or vancomycin or whatever that you use, and then closing back up, leaving the bone in place with drains, 2 drains in place, and then treat them with IV antibiotics for 6 to 8 weeks. And that's typically, we start with a broad spectrum antibiotic until we have cultures that come back that show what the infection is. Again, it should be pretty rare, but it can happen, especially with complex frontal orbital advancements, I think, because there's more bone that has been moved and is not vascularized. So, and we have found that we've not had to remove the bone, that it will heal in with the aggressive surgical debridement and IV antibiotics. Federico, what is your experience, or do you have any infections in France? Or
it happens, unfortunately. I mean, I think I wanted to start to say, oh, thank you, because I don't know what infection is, but it would be a lie, of course.
Yeah.
It's supposed to be rare. It's like Papillae. It's something that should be really, really, really rare. And it's something that should be rare because, as James said, your surgery is a planned surgery with a good context and so on. So what we do is the same. It's a shot of antibiotics before surgery. Then there is also one matter of discussion we did not have is duration of surgery. Your surgery should last little. So the procedure that the timing you aim to is 1 hour for a parietal remodeling, 3 hours for a frontal orbital advancement. If the more the child stays in the room, the higher the risk of infection. This is why also, because of the complex procedures like a frontal facial advancement and so on, there is a higher risk of opening the sinus, or longer surgery, there is higher risk of infection. But if you don't put any type of material, of hardware, if you don't burn your skin, if the flap is attached to the dura, then the antibiotics go on the bone, and your infection rate should be very low, 1 or 2%. So if your infection rate is higher, you have to question all the different steps. The skin opening, probably there is risk of ischemia or burning of the skin. Staples are too tight, or at the closure also, you close too tight and there is ischemia on the borders and germs will get in. Your drain, managing of the drain. Half of the planet does not use drain. I do use them. I like to have them as a monitor of the situation, but half of the planet does not use drain for a schistocephaly. So you can question yourself. Maybe you should go in your setting to a different type of monitoring, no drain, no source of infection.
Yes.
Antibiotics. There are 2 main schools. The major school is just during the surgery. There is another school is 1 week after surgery. This depends on the ecology of your hospital, the money cost for your hospital and for the patient, and so on. And then what happens if you have an infection? If you have an infection, it happens to me, again, as I said, unfortunately, if there is a real deep infection, I would go to reopen the scar at the level of the infection, remove the skin there, which is infected, and remove the piece of bone just over the infection. And you will see that the rest of the bone is already very tight to the dura. But the loose part, which is not tied to the dura, which is infected, you remove it, you close it directly, and then it's finished. You continue your antibiotic several weeks, and that's it.
Yes,
I don't know
sir.
if it answered your question.
Yes, thank you so much.
Great to see you, Dr. Hopp. Dr. Hopp worked with us in Birmingham for a while, and has done some great things in Hanoi at the National Cancer Hospital with Dr. Lien, one of our great colleagues there. So anyway.
Okay, so
to wrap up, yeah?
yes, please, Llewellyn. Yeah, go ahead.
Make some comments, you, and then I'll wrap up at the end, no?
Okay, I think we have covered everything. Thanks for John Bennett for this nice broadcasting, and also for Bello for the many nice comments he made. Thanks for the James Johnston for his nice presentation, and thanks Federico. I think we are on another date on the second Tuesday of every month. So please keep the date. And thanks everyone for the nice presentation, and thanks for the sharing of the comments.
Hey, yes, I'd like to thank Llewellyn and Muhammad for putting this great interactive discussion. The neurosurgery community benefits by this. And thank you, Federico and James, for taking your time to broadcast. And hang around to network if you'd like. We're going to end the broadcast. Thank you.
Thank you.
Thank you.
Thank you, everybody. Thanks,
Bye-bye.
Mohammed. Thanks, Llewellyn.
Thank you, everybody, and bye-bye.
Oh yeah, no, my
Appreciate it.
pleasure. Thank you very much. Thank you guys for doing this stuff. This is really important work. So thank you for doing it.
You're welcome.
All
Bye-bye.
right. Thanks, everybody. Good to
All
see
right,
you all.
Federico,
Take care.
thanks so much. Have a good
Bye.
soon.
See you. Too.
Bye-bye.
Bye.
Thank
See
you.
you again.
Bye-bye, Mohamed. Bye-bye, Lumen.
Hello,
Bye.
Patty.
Thanks, Federico.
Thank you, John.
Thanks,
Bye.
Bello.
Okay,
Thank you.
well,
Thank you,
thanks.
everybody.
Bye.
Patty, you there? Patty, are you there?
Hi, everybody.
Say
Thank
hi.
you
Hey,
very
Patty,
much. Very
put your
exciting.
face on the screen, Patty. Do you have your camera working today? No? Okay, that's okay. You don't have to.
Hi, everybody. Hello.
Welcome, Patty, from Argentina, Buenos Aires.
Hello.
Hi, Dr. Zanab, how you doing?
Fine, thank you, sir.
Could
How are you, sir?
could you please introduce yourself, Zanab?
Okay, sir. Good evening, good day to everyone. My name is Zainab. I'm from Africa, West Africa, in the Gambia.
Welcome.
Yes, thank you, sir.
How about you, Nora? You
Welcome.
want? Okay, yeah. Nora, you want to introduce yourself? Are you there, Nora? Okay, if you perhaps stepped away. Anybody else can introduce themselves? There's Patty. How you doing? Good to see your face. The Patty from Buenos Aires. She's a pediatric neurosurgeon, Llewellyn, from Buenos Aires, and she's from Bolivia.
Yeah.
I don't know. You going to go back there, Maria? Or are you going to stay in Argentina? You think?
I'm staying in Bolivia.
You're going to stay in Bolivia, huh? Well, that's great.
Yeah,
That's
great.
great.
Thank
Yeah,
you.
the pediatric neurosurgery niche is very active, Llewellyn. The last couple of years, for me, I did a lot in Latin America, pediatric neurosurgery with Patty and the pretty active pediatric neurosurgeons in that part of the world. And we hope to get them interested again.
Yeah. You had a Mexican pediatric neurosurgeon, a female earlier.
Griselda.
Good, that's right.
Yeah. Well, I've been down to Mexico with her. She's very active.
Yeah.
A little quieter now. People seem to go through phases. They get really active, then they kind of come. You know how it is.
Yeah.
Your world changes as a neurosurgeon.
Yeah.
Sometimes it's super busy. Other times it eases up. That's the way that I've been seeing it. But this is a good one. This is a good interactive one.
Yeah, it was great.
I don't know, sir. I don't know neurosurgery, but I know interaction.
No, John, thanks so much for doing this. It's been really helpful, and you've been fantastic in getting the logistics sorted out. So from Mohammed, myself, thanks so much.
Yeah, it's enjoyable.
Thanks,
it's very
John,
enjoyable. Really. It's catching on, so it feels good, that it's worth it. It's worth working hard. The neurosurgery, you learn quickly that hard work succeeds in neurosurgery. It's the same thing with internet, the same thing. The same work ethic. You're not going to get ahead in neurosurgery unless you work hard. The same in anything. So, okay, everyone, thank you very much. And this will be on the YouTube channel.
Nice
Thank you.
Bye, John.
Thanks.
Thank you.
Bye.